Topic of the lecture today is cardiac tumors and pericarditis. Now, cardiac tumors don't account for much of the pathological consequences or pathology of cardiovascular system, but when they do originate inside the cardiac cells, they lead to very major pathological consequences. We're going to talk about pericarditis next because some cardiac tumors may lead to pericarditis too. So before we talk about different kind of cardiac tumors, we have to talk about what's the classification like. What are the cardiac tumors classification? First of all, let's talk about the cardiac tumors which are either going to be secondary or primary. What do you mean primary cardiac tumors? Primary cardiac tumors are those cardiac tumors which originate inside those cardiac cells, which are basically primarily cardiac tumors. On the other hand, secondary cardiac tumors are those cardiac tumors which originate somewhere else in the body and then metastasize and come inside the heart and propagate there. Those are called secondary tumors. Now, in the secondary tumors, we're going to have metastasis. It can either be because of that primary origin, or it can metastasize from here too. Next on, we have primary tumors. In the primary tumors mean those tumors which originate inside those cardiac cells, originate inside the heart, and then move on to metastasis, or in some cases they are benign too. So the primary tumors, primary cardiac tumors are further divided into benign tumors. The example of benign tumor is myxoma. Next on, we have malignant tumors, which are going to be either sarcomas or lymphomas. Then further on, lymphomas have a type which is called mesotheliomas. So let's talk about these cardiac tumors. First of all, we're going to talk about the primary cardiac tumor and that benign cardiac tumor, myxoma. Now, myxoma accounts for 30 to 50% of cardiac tumors. It means if a patient is having cardiac tumor, there's 30 to 50% chance that it's going to be myxoma, because myxoma has the highest occurrence inside the heart in terms of the primary cardiac tumors. Now, myxomas, how does this form? Myxomas has been labeled that they have this genetic predisposition when the gene that codes for cyclic adenosine monophosphate is affected in any way, it leads to myxoma. When that gene that codes for cyclic AMP goes under mutation, that leads to myxoma, because not only that cyclic adenosine monophosphate working, not only that gene codes for cyclic adenosine monophosphate working, but it also codes for tumor suppressor. It also has a tumor suppressor effect, this product. This also has a tumor suppressor effect. When that is mutated, it may lead to myxoma. Now, myxomas are familial in nature too. It can also be inherited. Now, these myxomas basically occur in the left atrium. They occur in the left atrial chambers, and thus they can vary in size from 3 to 5 centimeter, and they can obstruct the mitral valve and the blood going from left atrium to the left ventricle. So in myxomas, they can also lead to obstruction of the blood going from left atrium to the left ventricle. So in myxomas, what we do have, or what we're going to get as clinical features, are first of all dyspnea, breathing difficulty. Patient is going to have breathing difficulty because if that myxoma, if that benign tumor is obstructing the left atrium to left ventricular valve, which is mitral valve, if it's obstructing that, what's going to happen? The blood is not going to go into the ventricle. The blood is not going to get pushed inside the bloodstream and not going to get to the tissues. And that left atrial blood is going to get pooled. It's going to go to the pulmonary vasculature. And when the pooling of the blood will start there, patient is going to have dyspnea. Patient is going to have breathing difficulty. Patient won't be able to take as much as air possible. Next on, patient is going to have chest pain or tightness because of this blockage, because of this tumor. Next on, patient is going to faint. When is patient going to faint? When the blood is not going through its normal pathway, when the blood is not going from left atrium to left ventricle, and then left ventricle is supposed to push the blood out inside the body, and all of those cells, tissues, organs are supposed to get oxygenated with that blood supply. when all of that pathway is obstructed somehow, this will lead to decreased perfusion of even brain, decreased perfusion of even organs, tissues, anything. Depends upon the degree of obstruction. Patient may faint because of decreased perfusion of those organs. Next on, we have palpitations. Patient is going to get palpitations because of it. Patient is going to get mitral valve dysfunction because of this obstruction. Patient is going to get mitral valve dysfunction. Next on, we're going to have tumor emboli, meaning that those 5 to 7 centimeter of tumor, maybe some part of it gets broken down and transformed into emboli and goes down the bloodstream and can obstruct somewhere else, can obstruct any vessel, can obstruct any valve, and this will lead to tumor emboli. So the patient is going to get these 6 clinical features. The patient will present to you with breathing difficulty, dyspnea, that's very common, that's with every respiratory and cardiovascular pathology. Patient is going to have chest pain, again it's common. Patient is going to faint. We have not discussed about it because fainting is of very peculiar nature to this disease, to these tumors. Patient may faint because of other reasons too, but if the patient is having all these symptoms with fainting, it's going to be because of myxoma. Patient is going to get tumor emboli and it's going to be of primary nature. Patient is going to have mitral valve dysfunction because of this tumor which is obstructing the mitral valve. The patient is going to get mitral valve dysfunction. Patient is going to get palpitations because of all of this pathology. Now let's talk about rhabdomyomas. Rhabdomyomas are the tumors of the children. Rhabdomyomas, as you can see, this is a rhabdomyoma. These are the tumors of the children and they occur in the 1/3 of the patients which suffer from tuberous sclerosis. So they occur because of the mutation in gene TSC1 and TSC2. Now TSC1 codes for hamartin. So any kind of pathology, any kind of mutation leading to the gene TSC1 and TSC2 will lead to this pathology of rhabdomyomas. Now these rhabdomyomas are either going to occur in left ventricle and right ventricle. In the start we thought it's going to affect one ventricle, but it's going to affect the both ventricles. So the both ventricles get affected in rhabdomyomas, and it also affects the atrium too. Unlike myxomas that affects the atrium, basically it affects both ventricles and atrium equally. And what we see is that it can range from 1 millimeter to several centimeters. As you can see, it's 5 centimeters at least of rhabdomyoma. The size may vary from millimeters, from 1 millimeter to several centimeters. It's pale in color. As you can see, it's pale in color, and it contains elastic cells, elastic tissue. It contains those connective tissues. So it's basically made up of this kind of tissue, elastic tissue, collagens, and there's that connective tissue lines that from the outside from which it originated. So that's what rhabdomyomas are. So next on, we have these papillary fibroblastomas. Now papillary fibroblastomas are not actually neoplasm. They're not primarily neoplasm. They are actually what? They are actually hamartomas. This debate is still going on, but they are actually hamartomas. These papillary fibroblastomas, as you can see, these are hamartomas which affect the heart in a very different manner than other neoplasms. Next on, we have other rare tumors. These three were the basic tumors which affect the heart: myxomas, rhabdomyomas, and papillary fibroblastomas. Now we have other rare tumors which are angiomas, fibromas, lymphangiomas, neurofibromas, and malignant melanomas. Whenever you hear the word oma, basically it's benign. So it's angioma, fibroma, lymphangioma, neurofibroma. On the other hand, we have this malignant melanoma. So these are the rare tumors of the heart. So what we have learned about that these tumors don't make up for much of the cardiovascular pathology, but when they do originate inside the heart, they lead to very extravagant pathological consequences. We talked about myxomas, we talked about rhabdomyomas, we talked about these papillary tumors. Now, these are the rare tumors which occur in millions, 1 in a million cases, which are angiomas, fibromas, lymphangiomas, neurofibromas, and then there's one malignant tumor which is malignant melanomas. Next topic we have to discuss today is pericarditis. Now, this word pericarditis gives it away. It means inflammation of the pericardium. So let me just tell you that there are basically two types of pericardium, this fibrous pericardium and serous pericardium. Now, fibrous pericardium is attached to your diaphragm. It's made up of basically connective tissue and this hard fibrous tissue. And then the serous pericardium is further divided into two types we just talked about, parietal and visceral epicardium, visceral pericardium. So these two types are the basic, the target of this disease, this pathology, this pericarditis. So as you can see, this is pericardium, normal heart, this is pericardium, this is the outer layer of pericardium. And then between the outer layer of pericardium and the inner layer of pericardium, we have pericardial cavity, which is filled with fluid. These are the two layers of pericardium. In heart with pericarditis, you can see that these layers of pericardium have been obliterated. There's that space that was supposed to be there, that fluid that was supposed to be there to protect the heart structure and to give and provide it with lubrication. Now that function is gone. It's either filled with a lot of fluid, which is far more than 50 ml that was supposed to be normally inside that pericardial cavity. And you can see now this has been compromised. And it is inflamed and thickened layer of the pericardium. They rub against each other and the heart. Now that fluid is either gone. Now that fluid either goes away or it's inflamed, or that fluid quantity has gone up to more and more level. And in this diagram, in this structure, what we see is that that fluid is gone, and now these two layers are rubbing against each other, and these are inflamed and they are thickened. Both of these layers are inflamed and thickened. So what are going to be the etiological factors for causing acute pericarditis? Before we move on to acute pericarditis, let me tell you that in that pericardial cavity, normal level of fluid is 50 ml. That provides the lubrication for it, that provides the nourishment for it, that provides that barrier that they won't rub against each other and lead to the pathologies. So up to much level, up to much extent, a fluid can get into that. If it's slow in nature, if the accumulation of fluid is slow, it can facilitate up to 2 liters of fluid without leading to consequences, without leading to cardiovascular consequences. But if it's abrupt in nature, if it's sudden in nature, 150 to 200 ml of water inside that cavity will give off cardiovascular consequences. So you have to know the amount of fluid it can facilitate when it's done slowly and when it's done abruptly. So let's talk about acute pericarditis now. What are going to be the etiological factors in acute pericarditis? First of all, if there's any undiagnosed viral infection, it will lead to acute pericarditis. If there's any rheumatic fever, it will lead to acute pericarditis. If there is any myocardial infarction, it will lead to acute pericarditis. If there is any breast and lung carcinoma, it will lead to acute pericarditis. And if there is any metastatic tumor, it will lead to acute pericarditis. Now, in all of these conditions, as you can see, in undiagnosed viral infection, it's going to get affected, it's going to go get inflamed, those layers are going to get inflamed, they're going to rub against each other, it will lead to pericarditis. In rheumatic fever, same is going to happen, it's undergoing a lot of pathology. In myocardial infarction, major part of the heart or major part of the cardiac cells have undergone necrosis because of ischemia, and because of that ischemia, it's going under necrosis. And after that necrosis, Yes, the blood supply is compromised of the heart, but so is the blood supply which is supplying these layers. If that is affected, that will lead to acute pericarditis, and breast and lung carcinomas can invade it. Breast and lung carcinomas can invade these layers and cause acute pericarditis, and metastatic tumors can invade these structures and lead to acute pericarditis. Now, these etiological factors have a major role in causing acute pericarditis. Let's talk about the pathological consequences. Now, this pericarditis, just we talked about this, this is going to be either fibrous, or it can be filled with blood. It can be filled with blood. So basic type of acute pericarditis that we know of is fibrous pericarditis. This diagram depicts fibrous pericarditis. In fibrous pericarditis, what we see is inflammation will be seen, and what we see is these tentacles of fibrous cells, fibrous tissues are seen in fibrous pericarditis. So in fibrous pericarditis, inflammation seen and tentacles of fibrous tissues, fibrous cells, fibrous layers is seen. That's what counts for the pathology of acute pericarditis in the case of fibrous acute pericarditis. It can either be blood inside of it. It can either be because of that. We're going to talk about it later in the slides. Next on, what are going to be the clinical features of the patient who is presenting to you with acute pericarditis? First of all, patient will say that patient is having sudden and severe substernal chest pains. Patient is having this pericardial friction rub because those two layers are inflamed now. They're rubbing against each other. There's no fluid present between them to facilitate that process. So they're rubbing against each other, and that is leading to pericardial friction rub. Next on, the patient will have repolarization abnormalities because of this pericarditis. Repolarization gets affected. Heart is unable to repolarize after the depolarization shift. When the heart is unable to repolarize, heart is unable to perform properly as a pump. Next on, we have constrictive pericarditis. Now, these further subtypes of pericarditis are actually consequelae of what happened in acute pericarditis. So, chronic pericarditis is actually a chronic disease, a chronic inflammation, or you can say obliteration of those pericardial layers, which happens because of what? An acute pericardial injury. An acute pericardial injury happened, and afterward, that acute pericardial injury, the heart started to heal. But in that healing, what happened is that parietal layer and the visible layers are now fused with that fibrous tissue. Are now fused because of that fibrous tissue, and that fibrous tissue has, made its way to them, and now they are fused together. And when they fuse together, there is not much of any fluid between them. So now they're fused, and what happens then? They constrict on the heart. When they constrict on the heart, they stop the heart from dilating. When they stop the heart from dilating, what will happen? Diastolic dysfunction will happen inside the heart. Their constriction can go up to such extravagant levels that they can even obstruct the vena cavas. When the vena cavas are also affected, what happens is the heart is unable to get the blood enough. This will lead to constrictive pericarditis. This is a depiction of constrictive pericarditis, in which you can see that these layers look like a fibrous material which are constricting the heart, and they're not letting the heart expand, and they can even obstruct the vena cavas and lead to this kind of pathology called constrictive pericarditis. So in the pathological consequence, you can see in this gross diagram of constrictive pericarditis, now these two layers are fused, they're constricting the heart. You can see they're constricting the heart, they're not letting the heart dilate, they're not letting the heart get more and more blood to pump out of it. They're even obstructing the vena cavas in this case. Next on, we have the clinical features of constrictive pericarditis. As you can see, what are going to be the clinical features of a patient which is suffering from constrictive pericarditis? First of all, patient is going to have small, quiet heart. Why small, quiet heart? Because heart is not pumping properly. Heart is unable to dilate. Heart is unable to pump properly because of this constriction present on them, which happened because of what? That serous epicardium. Those layers, those pericardial layer, visceral pericardium and parietal pericardium are now fused together with that fibrous material. They're not letting the heart expand, and this will lead to small, because of that fibrous material surrounding the heart all over it, and quiet hearts because it's unable to perform its function properly, and because of this covering outside of the heart, this is small and quiet heart. Next on we have high venous pressure. Why are we having high venous pressure? Because when the left ventricle cannot expand properly, when the left ventricle cannot contract properly, when they're not getting enough blood in, where the pressure is going to go, where the blood is going to go? Left atrium. When the left atrium is also under the same kind of pathology, what's going to happen? The pressure is going to go onto the pulmonary vasculature. And then pulmonary vasculature, from the pulmonary vasculature, the pressure will go all the way to the right ventricle. Now, even the right ventricle can't expand because it's enclosing the heart properly. Right atrium. Then right atrium can't expand. What will happen? Now, even we talked about the vena cavas are being constricted. So what are going to be the consequences? Venous pressure will rise up. High venous pressure will be seen. Pooling of the blood will be happening. This will lead to low cardiac output because not enough blood is inside those chambers to make the cardiac output go high or up. So there will be low cardiac output. There will be small pulse pressure. What's pulse pressure? Pulse pressure is the difference between systole and diastole. Systolic pressure and diastolic pressure is called pulse pressure. So when systolic pressure is down, diastolic pressure is down, small pulse pressure will be coming out of it. And then we have fluid retention. Why are we having fluid retention? Because of high venous pressure. Because the blood is being pooled inside those veins. Because the blood is being pooled inside that venous vasculature. Because the heart is enclosed, the heart is under constrictive pericarditis, it cannot expand properly. So the blood is pooling inside those venules, those veins, and when the blood is going to be pooled in them, fluid is going to leave those vessels and lead to edema and fluid retention. This will lead to ascites and peripheral edema. Ascites will happen inside your abdomen. When the fluid will leave those veins inside the abdomen, it will lead to ascites. And when that fluid will leave the vessels inside the peripheral areas, it will lead to peripheral edema. Now let's talk about adhesive pericarditis. As the name confers, what is adhesive pericarditis? Adhesive means adherence. It means adherent, together, kind of glued together. Now, adhesive pericarditis can be between those two pericardial layers. It can be between that pericardial layer and the heart. And it can also be between pericardial layers and the neighboring structures. So, adhesive pericarditis is going to be those pericardial layers being adherent to each other, or the heart, or the neighboring structures. That's what adhesive pericarditis is. Now, it has the same clinical manifestation and the pathological consequences as obstructive pericarditis. But what it does is that it has different points of attachment. It is not attached throughout the heart. It has different points of attachment. It is not attached throughout the heart like constrictive pericarditis. It's different from that. So it has lesser degree of pathological consequences than constrictive pericarditis. Next on we have pericardial effusion. In pericardial effusion, the fluid is accumulated inside the pericardium. What happens is that this, as you can see, this is a normal heart. In pericardial effusion, fluid is accumulated inside the pericardium. Now this pericardial cavity, you can see this is a normal heart, normal pericardial cavity. Now this is filled with any kind of material. It can either be fluid, it can either be blood, it can either be anything. But this is called pericardial effusion. Now 20 ml to 30 ml in some books, and in some books it's 50 ml. It has been depicted that it can contain between these layers 50 ml or 20 ml can be normal. It's present there to oppose that friction rub, to facilitate, to accommodate, and it gives off that, it stops that friction rub. So it's present here, but slowly, if it happens slowly, I just told you before in the pericarditis section that if it's filled with any kind of fluid, it can accommodate up to 2 liters of fluid, and abruptly it can accommodate up to only 150 ml. When slowly it happens, it takes more than 2 liters to lead to cerebrovascular consequences, to lead to those symptoms that we know that, okay, this patient is having pericardial effusion. But if it happens overnight, if it happens rather quickly, 150 to 200 ml of fluid will give off all those signs and symptoms of cerebrovascular involvement and consequences. So what are the further types of pericardial effusion? First of all, we have serous pericardial effusion. Now, serous pericardial effusion works exactly like nephrotic syndrome or congestive heart failure. Now, serous pericardial effusion leads to increased extracellular fluid. That increased extracellular fluid has decreased number of cells and all of that, but it has increased fluid, so it will be just like congestive heart failure patient or nephrotic syndrome patient. Next on, we have chylous effusion. Chylous effusion means chylomicron containing those vesicles or fluids. Now, chylous effusions, what's different with chylous effusions? Chylous effusions occur when thoracic duct is directly in contact with pericardium. It can be because of any tumor, it can be because of any metastatic tumor or cancer or any obstruction that will lead to thoracic duct being in contact with pericardium, and that will lead to chylous effusion, type of pericardial effusion. Next on, we have serosanguinous pericardial effusion. Now, in this pericardial effusion, what happens is that the patient has undergone, or the person has undergone, rather abrupt consequences. It has happened because of any direct injury to the vasculature or to the heart. It can be because of any abrupt injury to the chest, or it can be because of CPR. In an attempt to survive or revive a patient, we go for CPR, cardiopulmonary resuscitation, and we rupture it, and it led to pericardial effusion. This type of pericardial effusion is called serosanguinous pericardial effusion. Last but not the least, we have hemopericardium. Hemo stands for blood. You can see hemopericardium is because of many reasons, but the very basic reason we know that because of any obstruction or because of any kind of pathology, when the free wall of the left ventricle bursts, it leads to accumulation of blood inside that cavity, and that kind of pericardial effusion is called hemopericardium. It can either be because of direct trauma to the chest, it can either be because of any direct injury to the heart or the vasculature, but basically it's because of the rupture of the left ventricle's free wall. Next on, we have cardiac tamponade. What is cardiac tamponade? Cardiac tamponade is a syndrome which occurs because of rapid accumulation of blood or any kind of tissue inside the pericardial cavity. Due to this rapid accumulation of blood or this fluid, what happens is that heart is now restricted, and heart cannot pumps properly. It's restricted because of this fluid. That's what cardiac tamponade is. This is what cardiac tamponade syndrome is. So with time, this pericardial pressure goes on increasing and increasing and increasing and increasing, and at certain level it reaches the pressure of the venous vasculature. It reaches the venous pressure, and when it surpasses the venous pressure, it stops the filling of the heart. And when it stops the filling of the heart, rather pathological consequences come in because of it. It stops the filling of the heart, and with time, you will see a phenomena called pulsus paradoxus. Now, what is pulsus paradoxus? Pulsus paradoxus is a phenomena in which the filling of the heart is rather, or the cardiac output and everything regarding that goes down with inspiration. That's what pulsus paradoxus is. As you can see, this was happening, and this was filling the pericardial cavity with the blood, and up to certain level it reached up to certain pressure, it reached up to certain level that it stopped the filling of the heart, it exceeded the venous pressure, and now the filling of the heart has been compromised. Next time we're going to talk about the metabolic diseases of the heart. First of all, let's talk about the hyperthyroidism. Now, what metabolic diseases can affect the heart, and in what way? Among those metabolic diseases, we have hyperthyroidism on top of it. Now, what's the function of thyroid levels? How does thyroid hormone affect the heart? It increases the cardiac output. It causes tachycardia. So, as we know, it causes tachycardia and more cardiac output. Now, if a patient is suffering from certain pathology and has gone under bradycardia and is going under some different kind of pathologies, you might give thyroid levels as treatment to that patient for getting the heart rate above the normal or into tachycardia, and it will give off more cardiac output and the patient will be fine. So if thyroid levels are in sporadic form and are in controlled manner, they can even lead to the treatment of certain diseases. But what if the hyperthyroidism has happened to that patient and those thyroid levels are high all the time? Because the patients suffering from hyperthyroidism don't even know that they're suffering from hyperthyroidism for a very long time, until they suffer from the consequences of them, until they come up with those serious signs and symptoms, until they come up with heavy weight loss, heavy sweating. Until they come up with those signs and symptoms, they don't even know about those hyperthyroidism. So what if the patient is already suffering from hyperthyroidism? So if a patient is suffering from hyperthyroidism, it can be either primary or secondary, it can be thyroid tumor, it can be anything. Any of those may lead to increased thyroid level inside the body. When thyroid levels inside the body are high or up, what will happen? Tachycardia and more cardiac output. Now that heart which was pumping at 60 beats per minute is now pumping at 100 beats per minute. What's going to happen? Increased cardiac workload and angina. So the cardiac workload has increased up to at least 50%. So what else will be increased to make up for this workload? Oxygen supply. Now, if heart is pumping at 100 beats per minute, it needs more and more oxygen than it was needing before. So in order to compensate that, what will happen? Patient will be breathing thoroughly. Patient will breathe more and more oxygen. Patient will be dyspneic. Patient will breathe more and more air, so that more and more oxygen can be taken up by the blood supply and go into the blood and go into the heart, and then face this tachycardia and more cardiac output and face this increased cardiac workload. But what if due to any pathology? What if due to any pathology of respiratory system, or what if due to any pathology of cardiac system, or due to any pathology of coronary vessels, or due to any pathology of not even coronary vessels, but if the heart rate has exceeded all the limits? What if due to any of these reasons, the oxygen which was needed for the heart to increase at this workload is not compromised? If the oxygen is not enough, patient will experience angina. Now this angina can be due to anything. It can be due to any kind of thrombosis or atherosclerosis inside those coronary vessels, or it can be because of any vasospasm or any pathology. So if there's any pathology regarding that, patient is going to experience angina. And when the patient is going to experience angina, what will happen? High output failure and arrhythmias will happen. Because heart is unable to to even saturate itself with that amount of oxygen that can comprehend this increased cardiac workload. Now, this increased cardiac workload was implemented by hyperthyroidism, was implemented by this high thyroid levels. When these high thyroid levels came in, they caused this tachycardia, they caused this more and more cardiac output. Up to certain levels, yes, the compensatory mechanisms turned on, and more and more oxygen is being consumed by the lungs, and more oxygen is coming into the heart, and more oxygen is being supplied to the heart by coronary vessels. But after a certain limit, due to any pathology, and that pathology may be due to any pulmonary pathology and any cardiovascular pathology, any coronary pathology, this blood is not enough to saturate its own heart. It will lead to angina. And if the heart is pumping at this level at 100 beats per minute and it's not getting enough oxygen due to any pathology, this will lead to high output failure. And if some kind of ischemia happens, if myocardial ischemia comes in and ischemia happens and some cells are necrosed or some cells are dead, this will lead to arrhythmias now. So hyperthyroidism may lead to high output failures and arrhythmias just by causing tachycardia and more cardiac output throughout the time, all the time. Because this way the heart will be pumping at more and more speed, but the heart supply of oxygen through coronary vessels is not enough to keep the heart pumping at this speed or at this level. Next on, we have hyperthyroid heart disease. It will be poor contractility, it will be pulse pressure low, it will be pericardial effusion, it will be cardiac output low, and next one will be basophilic degeneration. Now let's discuss all of these 5 phenomena together. We talked about this hyperthyroidism, we talked about this hyperthyroid patient, we talked about how it's going to be. Now, first of all, it says here that patient is going to have poor contractility. Why? We know that heart acts as a pump. When heart acts as a pump, it relaxes and then it contracts. It relaxes and then it contracts. This contractile nature, this contractile force is the force which pushes the blood from left ventricle inside the whole body. If by any phenomena, if it's because of this muscle degeneration, if it's because of any phenomena, this contractility is gone, heart won't be able to pump properly. If heart is not pumping properly and it comes off at this level and stops, heart is not pushing enough blood out of the left ventricle. Ejection fraction is down. When ejection fraction is down, whole body is going into hypoxia because all those tissues, all those cells, all those organs are not getting enough of the blood supply they were supposed to get. Now, in this instance, we talked about any pathology, but let's talk about this hyperthyroidism. Let's talk about this hyperthyroid heart disease and this pathology. What happened in this? We're talking about tachycardia. For example, a heart was pumping at this speed, right? It's 60 beats per minute, heart is pumping. But thyroid levels came in due to this hyperthyroid patient. Now, thyroid levels came in and they're asking the heart to pump at a rather more speed. So what will happen? Now, this heart has to pump at 100 beats per minute. So maybe the heart will come to this level and go back, come to this level and go back, come to this level and go back. Now, this is the only way the heart can compensate and increase its beating times per minute, increase and lead to tachycardia. Now that heart which is pumping at this level and the contractility was up to the mark to push the blood out of it, and that blood must reach those cells and tissues even at the peripheral levels. Now the heart is pumping like this. Now it's just tachycardic, it's not pumping enough to push the blood out of it. Now it is pushing the blood out of it, but not with enough pressure, and contractility is compromised in this case to make up for that tachycardia. Next on, we have pulse pressure low. What do we mean by pulse pressure low? What is pulse pressure? Pulse pressure is difference between systolic and diastolic blood pressure. So before that it was 120/80, now it must be below that because heart is not pumping at 120, it's stopping rather in between. So for example, if it's 100 by 80, pulse pressure is low, it's 20. So pulse pressure of the patient is going to go down. Next, now we have pericardial effusion. Pericardial effusion will come in because now the heart is pumping at rather vigorous speed, rather vigorously it's pumping. The fluid will start accumulating, the fluid will start leaking, or the rupture of the wall will happen, or any of the pathologies will lead to pericardial effusion. We just learned about pericardial effusion. It can be any of those substances. Now the pericardial effusion will come in. When the pericardial effusion will come in, what will happen? It will increase and surpasses those venous pressures. When it will increase and surpasses those venous pressure, cardiac filling will be compromised. When cardiac filling will be compromised, patient is going to go into congestive kind of heart failure. Now, after all of this, patient is going to have cardiac output low because due to pericardial effusion, filling of the heart is compromised. Now, the filling of the heart is not happening up to that mark. And if it's not filling properly, how it can give off much blood? If it's not filled properly, it's just like if a glass is half filled, how can you expect it to fill the other glass completely? So it's not filled properly, so the cardiac output is now low. When the cardiac output is low, what will happen? Ischemia will happen to other organs, to heart itself, because enough blood supply is not going their way. Enough blood supply is not going their way. And what will happen to the venous pressures? Now the venous pressure will start rising, and they will lead to the accumulation of blood inside those venules, inside those venous system, and that venous system will lead to pulmonary edema, that system will lead to peripheral edema, that will lead to ascites. Now all of those are the consequences of this similar pathology. And when the cardiac output goes low, basophilic degeneration of the cells will start happening. Now the basophilic degeneration of the cells will start happening because they're not getting enough oxygen, they're not getting enough blood, they're not getting enough nourishment, so they will go under degeneration. Next on, at the end, we have beriberi heart disease. Now in metabolic disease of the heart, we have this beriberi heart diseases. Beriberi heart disease is further divided into two types. Those types are wet beriberi and dry beriberi. Before we dig into wet beriberi and dry beriberi, we have to know what's the cause of beriberi heart disease. In metabolic system, beriberi heart disease happens when a person or that patient is suffering from beta-1 or thiamine deficiency. So this disease is because of beta-1 or B1 and thiamine deficiency. When both of these are deficient and are low in quantity, that leads to beriberi disease. Now, beriberi disease has further two subtypes I just told you. It's either wet beriberi or dry beriberi. Now, both of these have different kind of involvement. Wet beriberi affects the heart and the circulatory system. In severe cases, it causes heart failure. On the other hand, dry beriberi affects the nerves, affects the muscles, and in severe cases it causes muscle paralysis. Yes, they are very different from each other. This will lead to decreased peripheral vasculature resistance, increased cardiac output and heart failure, and dilated heart non-specific changes. Now, how are these coordinated? In beriberi heart disease, due to this thiamine and beta-1 deficiency, what happens is that there's decreased peripheral vascular resistance. Due to this, increased cardiac output is coming on because peripheral resistance is down. Now increased cardiac output is coming out because what was stopping that cardiac output? Peripheral resistance. Now if that is down, more and more cardiac output is coming out, and this will lead to heart failure. And all of this pathology leads to dilated heart non-specific changes. In this disease, heart does go through different kind of dilation, different dilated heart diseases, but it's non-specific. It's not like only left ventricle is going to get affected. It's not like only right ventricle is going to get affected. Now here's where wet beriberi comes in, that it affects the heart, it affects the circulatory system, and it affects in very different manner every time. So there's no connection to it. It's non-specific. These changes are non-specific, and it affects the heart, and in severe cases, it causes cardiac failure. And what about dry beriberi? It causes the muscular involvement, it involves the nerves, and in severe cases, it paralyzes those muscles. So that's all for this lecture about cardiac tumors and pericarditis and all of these pathologies which are related to it. Thank you for watching sqadia.com.